Day for month of May with us. And a warm welcome to our resource personnel, Professor George Hidalgo, Dr. Anushka Mudalige, and Dr. Lilanti Subasinghe, and Dr. Quinta Jaya, who will be doing presentations today on behalf for this special day. So, introduce each speaker. The first speaker, I will hand over to Dr. Dilshantu.
Thank you, sir. Um, Good morning. I would like to thank the Ceylon College of Physicians for giving us this opportunity. It's been conducting each month, and I'm really happy that the month of May is dedicated to the specialty of critical care medicine. So, so we have three talks here, which includes one case-based discussion at last. So, without delay, I would like to introduce this first speaker. He's Professor George Hidalgo. He's a professor of critical care and head of the division of critical care at Carl Houston Memorial Hospital in Belize City in Belize. And Professor Hidalgo was appointed president-elect in September 2021 and will assume the presidency at the 16th World Congress in Istanbul this year. And he holds many positions in prestigious institutions and contributed immensely to the field of critical care. As you can see on the screen, his contribution and the achievements. So without any delay, I would like to invite Professor George Hidalgo to begin his talk.
Well, first of all, I would like to thank you for the kind invitation. I would like to thank in particular to the CCP Speciality Update in Critical Care Medicine. That is a program that in collaboration with the Ceylon College of Critical Care Specialists. And I would also like to thanks Dr. Professor Dominda Monidasa, the president of the Ceylon College of Physicians. And also I want to thank Dr. Anushka Mutilagi for the kind invitation. I'm Dr. Jorge Hidalgo, and I am the president-elect of the World Federation of Intensive and Critical Care Medicine. And also I am the head of the critical care medicine unit and the COVID-19 at Belize Healthcare Partners in Belize. And what we are going to trying to intend to talk today is about a couple new things that we are call our attention and is becoming of very interesting topic in critical care medicine. And we will talk about the systemic microbiome, also how they diverse the microbial communities and how they does influence our health and also impact on the disease. All of us agree that the healthy human body is the home to abundance of bacteria, viruses, and fungi that are essentially acquired just immediately in our postnatal life. And also we know that the bulk of this microbiome is located in the gut, but we need to know also that there are other microbial communities like we have in the skin, in the mouth, nose, lungs, in the genital tract. The human microbiome has important roles in the maintenance of the homeostasis, and any situation that it will cause a disruption on the microbial colonization of an infant will impact and influence health in later in life, with potential promoting of development of autoimmune problems, allergies, metabolic diseases, and lately as we are going to see in the following slides, also is being related with certain type of cancer. And I don't have no conflicts of interest in this topic in this presentation. And as we mentioned, no, we see this multiplicity of microbiomes, and given the abundance interaction among this diversity of microbial communities, in certain part it will influence physiology. If a microbial population is disrupted because for any situation, either our use of antibiotics, our diet, uh, then also certain pathogens can gain advantage, and also it will cause some systemic inflammation, infections, and definitely it will cause and will put us essentially prone to develop certain conditions. No? Mean that our understanding on the ecology as well as the different mechanisms of how this communication between the host and this microbial, our understanding on that definitely it definitely can offer a more holistic view on our human health. And of course we would like that understanding to contribute to preventing and also to treating a spectrum of different human diseases. But of course, is something that we need to gain more understanding. I mean that we definitely need to consider as an essential metabolic organ the microbiome, and we plays a role in this human predisposition of disease, and the understanding and is essentially getting more and more. I mean, as we know, there are many factors that we found that it will alter, or in a way it will affect and influence the gut microbial composition, and that it will say environmental situations, the antibiotic usage, the genetics, and the diet. And then we know that those it will essentially have an impact, especially the diet and the genetics as a one of the most important driving forces in our knowledge and understanding of the microbiome. I mean, and this is a interesting slide for Gottridge et al. That it will essentially trying to understand the evidence that host genetic as an alternative driver for the gut, and also the microbial variation. We see that some mammal exhibit mark individual variation in the gut microbiota, but it remains unclear if it's essentially primarily driven by host genetic or by extrinsic factors like the diet, no? That we will uh, review in more detail. Then we then encounter some terms like the humans and the holobionts. And what we mean with a holobiont, when we talk about the holobiont, we want to try to say that it's essentially an assemblage of hosts and also the many other species living in or around it. And of course, that essentially we create a discrete ecological unit through symbiosis. And of course, that is something that is very interesting. We know that the gut microbiota influence the immune system, energy biogenesis, biosynthesis of vitamins and hormones, and our metabolism. But also, as we will review later, also is being implicated in the appearance of conditions like diabetes. Also, we see some inflammatory bowel disease, ulcerative colitis, multiple sclerosis, that are associated with the gut microbiome. Mean that the understanding of this microbiome and how and the role that plays in all this is very interesting because it provides an attractive target for some therapeutic interventions. I mean, that we see right here that the stool sample is an adequate representation of the gut content. And as we see, this is the biogeography of the intestine, and we'll see by anatomic location in the gastrointestinal tract, the stomach, the small intestine, the large intestine, the mucosa, the colon, and the duodenum, and see the different types of bacteria that we see. I mean that it's very interesting because then we know that the microbiome have multiple functions that are essential, uh, like the promotion of fat storage, promotion of angiogenesis, uh, also development and training of the immune system, uh, and also biosynthesis of vitamins and amino acids, metabolism and therapeutics, modification of the nervous system, breaking down in food components, resistance of pathogens, protection against epithelial injury or modulation of bone density, among other functions. Mean that the gut microbiome appears altered in many chronic diseases, as we know, is implicated in the appearance of conditions like the rheumatoid arthritis, type 1 diabetes, inflammatory bowel disease, pulmonary disease and atopy, carcinogenesis, obesity, atherosclerosis, non-alcoholic liver disease, and inflammatory bowel disease. And we know that 7 of these 10 causes of death in 2010 were chronic diseases. I mean that is definitely something that we need to have in consideration. I mean that essentially, as we know, the oral microbiota, as we essentially focus on the gut microbiota, but we will touch bases on the different microbiota, and then we'll see that the oral microbiota form distinct biofilms in different regions of the mouth that protects the host and tissue. And with homeostasis between host and the microbial is lost, then this oral microbiota can affect distant tissues and influence, for example, colorectal cancer cells, proliferation, and autoimmunity that leads to rheumatoid arthritis. Then we see right here that the some implications on that. We have right here the supragingival biofilm and the different bacteria, and the dorsal tongue biofilm and the different bacteria. And the oral microbiota can influence diseases like colorectal cancer and rheumatoid arthritis, and we see the different inflammatory mediators on these processes. Also from the discovery of the roles of the gut microbiota in metabolic disorders as obesity, to recent discoveries of the gut microbiota modulating responses to cancer immunotherapy, the microbiome research definitely has expanded to all areas of biomedical research over the past 15 years. And some of the vital roles for the microbiota is the brain communication, in brain development, behavior, and function that has emerged. We see in this slide some metabolites that eventually can be explored as a therapeutic approaches, such as the BA 2004 to reduce ethylene phenyl sulfato, and how that can influence certain conditions, as the microbiome has been implicated in the progression of the amyotrophic lateral sclerosis and autism, and then certain of these elements can have some implication, therapeutic implication in these two conditions. Definitely, most evidence linked to the gut microbiota to brain phenotypes and behaviors is from animal models. These preclinical studies have provide us with certain information and strategies to further analyze and intervene in humans. Of course, what is needed is basically inform causality in humans. We need to understand the effects in our lifestyle. We need to be able to use more accurate controls, understanding the contributions on genes, environment impact, and we need to have trying to document the complete inventory of human associated microbiota, define the directionality between cause and effect, perform a large scale translational and longitudinal studies, and to be able to define normal and healthy gut microbiota. Mean that the human skin definitely forms a protected barrier against the external environment. I mean that we know that our lifestyle factors can alter that barrier, the use of skin products, social and physical, environmental, use of antibiotics, aging, environmental factor, local host factors, skin commensals. I mean, those are different factors that influence the microbial colonization of the skin. I mean that as we see the skin microbes form definitely the first barrier against the environmental through various mechanisms of colonization resistance. We have the microbial barrier, chemical barrier, immune barrier, and physical barrier. And that's skin microbiota mediates these multiple levels of barriers. I mean that is important because the microbes boost the chemical barrier of the skin by producing different type of lipases and different other mechanisms. But finally, we know that the microbiomes, it will stimulate our innate and also our adaptive immune system of defense, such as releases antimicrobial peptides induction in the neonatal, and also it will help us to develop most protective immunity. This slide is very interesting because it helps us to understand the different implications of the skin cross communication, and also how this is driven by host mediator communication and interactions. We see right here in A how this keratinocyte and interleukin 36 and immunoglobulin, serum immunoglobulin E can, because of allergic sensitization influenced by Staph aureus infection, it can create inflammation. In B, we see right here that skin injury releases hyaluron fragments that at some point it will can promote gut inflammation. Skin infection by Staph aureus can also create some pore forming toxins, and these pore forming toxins can serve as a receptors and also promote pain. And finally, right here in D, the gut microbiota and our dietary fiber contribute to melanoma response to the immune checkpoints, and also it can driven cytotoxic T cell accumulation and killing tumor cells. I mean that those are just to give you some of the examples of that. I mean that and illustrated is an example of this pipeline for using skin microbiome profiles to inform functional and mechanistic investigation of applying this combination of culture independent and culture dependent approaches that it will allow examination of the specific microbes and the consortium in the context of the skin model systems. No, I mean that more and more we are understanding and getting know the microbiome. The research, of course, of the newborn immunity has revealed the importance of cell autogeny and also the feto-maternal tolerance and the transfer of maternal antibodies. Now, this is just an example of the prenatal preparation in birth and also in the adulthood, and how this it will influence our immunity. This is another window opportunity for immune that illustrates immune maturation. I mean that this is an example of a mismatch between ancestral and modern environments and altered trade-offs between growth and immunity. We see right here the ancestral environment, our early life environment, and our adults, and how this it will influence our evolution and development. And at the end, it will essentially it will promote inflammatory response against our microbiota. Mean that this is a model of a genetic mucosal surface showing microbiota host interaction at the interface. And we see homeostasis and we see dysbiosis. Now we know that dysbiosis is in those, it could be triggered by antibiotics treatment that can allow expansions of pathobionts because of the loss of commensal microbiomes. Now we see all these different omics and screen initiated approaches in the microbiome research. We see the implication of humans with a disease or animals with phenotype. They associate microbes, molecules with disease phenotype, isolation of putative effectors, microbiome, functional validation, the rationality of these designs, and microbial-based therapies. I mean that there are a lot of new things that we are trying to understand, especially in the age of personalized medicine. I mean that these mechanistic microbiome studies with integrated approaches to find disease targets, approaches of microbiome studies are important and has been established by integrating experimental and computer methodologies. Now we have these human studies with new hypotheses, in vivo studies, hypothesis generations, in vitro studies, and then these multiomics in the human microbiome, meaning that our knowledge and our understanding of the microbiome is essentially really important. Or just as we know in the ICU, just recently we have many articles like how things like selective digestive decontamination it can help. No, using a selective decontamination is a strategy that essentially is with the idea to reduce the risk of hospitalized acquired bacterials and yeast infections among others. No, also we know that certain brain gut microbiota interplays with depression, a key to essentially to design new different therapeutic approaches. And we know, and also there are some studies saying how over different type of variation in diets, like Western diet, it can implicate and influence the different type of microbiota. Like the Western diet can favor E. coli, and those can increase inflammation and oxidative stress. The vegetarian and vegan diets also, it will promote the appearance of different type of bacteria, among other Clostridium enterococcus, and that can increase immunity, but also can reduce inflammation of oxidative stress. Now, in the age of the ketogenic types of diets, also we know that they will favor certain type of bacteria, and the Mediterranean diet as well, mean that more and more we are trying to see, and also these diets have been implicated in depression, and then is helping to develop new targets. No? Mean that definitely, in summary, our understanding on the microbiome, it will exert essential functions in health and diseases, modulating key processes in the metabolism, inflammation, and immunity. We need to also recognize that the certain terms like dysbiosis, that will refer to a change in the composition and the diversity or metabolites in the microbiome from a healthy pattern to a pattern that is associated with a disease or predisposition to a disease. With that, I also want to invite you guys to participate in the 60th World Intensive and Critical Care Congress that is going to be held in the city of Istanbul, Turkey, during the 26th to the 30th of August of 2023. With that, one more time, I want to thank the organizing committee of this symposium to allow me to share with you. I need to apologize. I'll be unable to stay for the answer and question because I have another commitment that I need to attend immediately. And that with that, thank you one more time for your invitation and for your attention.
Thank you very much, Dr. Halango, for joining us today. Since I think he's busy with another meeting, probably we'll not have any questions time for this. So we'll move on to the next speaker. Dr. Dilshan will introduce.
So the next speaker will be Dr. Anushka Mudlige. She's a consultant intensivist at intensive care unit at the Colombo North Teaching Hospital, Ragama, and she's the current Secretary Scientific Affairs of the Ceylon College of Critical Care Specialists, and she has contributed immensely to the field of critical care medicine in Sri Lanka. And we would love to hear what you have to say on the failing liver in the ICU. Over to you, Anushka.
Thank you very much, Dilshan. So also thank you CCP for inviting us to do this special update this month. We are honored from our college to be talking to this prestigious audience here. So without further ado, I will move on to my topic. This is the failed liver in ICU, an evidence-based update. And during this talk, I'll be talking about the definition of acute liver failure, the pathophysiology and clinical manifestations, and management and prevention of multi-organ failure associated with acute liver failure. So the evidence is from the USA and the European societies where they have given guidelines for acute liver failure. But saying that, even in the USA, the occurrence of acute liver failure is very scarce. It occurs about 2,000 per year for the whole population of 330 million. In the UK, it is about 1 to 4 per million of population per year. So as you can see, the occurrence is really low. So we cannot have good randomized control trials because the number is low. So what they have done is they have inferred evidence from sepsis, because acute liver failure mimics sepsis a lot, and also from cirrhosis. So this is how the guideline, what I'm going to talk about, is based on. So acute liver failure, what is it? It's a triad of coagulopathy, encephalopathy, and hypobilirubinemia occurring in a patient who does not have pre-existing liver disease. So as medics, I think you already know the etiologies of acute liver failure, so I'm not going to go through the explaining. And as you're well aware, in the East, it's more of viruses, hepatitis A, E, and B, and while in the West, it's more of paracetamol and other causes. So we grade acute liver failure. So there are many grading systems here, but what we usually use here is the O-grade system, and the grading depends on the timeline. From the occurrence of jaundice to the occurrence of encephalopathy. If it occurs within 7 days, it's called hyperacute. Within 1 week to 4 weeks, it's acute, and from 4 weeks to 12 weeks, it's subacute. So why do we need a grading system? It's because it is related to the prognosis. So here, the better survival is with paracetamol, hepatitis A, ischemia, and acute fatty liver of pregnancy. They have better survival compared to hepatitis B, autoimmune, drug-induced, and indeterminate causes. And if you look at the timeline, the hyperacute and the acute liver failure have the more favorable etiologies, whereas the subacute has the ones that have kind of a lethal outcome. So here also, if you can appreciate this is survival against the etiologies. So even though the favorable etiologies do have a considerable amount of encephalopathy, they do survive compared to the unfavorable etiologies that you see. It's less than 25% the survival of these etiologies. So a little bit about the pathology. So all these etiologies that I've assumed that we have talked about will lead in some way to necrosis of the hepatocellular cells. For example, paracetamol will cause an increase in NABQ, which will cause liver damage, and autoimmune will cause antibodies. So all these will somehow ultimately lead to necrosis of the hepatocytes. The good thing about the liver is it can regenerate. But when the necrosis exceeds regeneration, the liver cannot cope up with its functions. Also, the liver is an amazing organ where, when it is injured, it is able to produce all these metabolites. I think Professor Hidalgo also explained a lot about this omics. And so all this is related to all that also. So this soup of metabolites that are released to the systemic circulation will go into all the other organs who are minding their own business and doing their work fine. And then they will also get disorganized at this point. So let's talk about the liver first. So with the necrosis, it will release all the enzymes that are within the liver cells. There will be upper quadrant pain because of the autonomic system getting involved because of the inflammation. And the toxins, our main organ of detoxifying is the liver. So the toxins get accumulated, which will lead to hepatic encephalopathy. and the synthesis will get affected. The INR will go up, bilirubins will go up, there will be jaundice, and the complement system, which is produced by the liver, is also affected. So as a result, they will end up having infections. So all the metabolites that were released to the circulation will cause problems in all of your organs. So it's a hyperdynamic circulation. The brain, lungs, everything will get affected at some point. So it's actually, it's kind of sepsis because it has a systemic kind of role. Although we talk about acute liver failure, it is not just one organ that fails, it's the whole body kind of going into failure. So a little bit about a hepatic encephalopathy. So all the cytokines that were released have already caused some damage to the blood-brain barrier. And the main culprit is the ammonia, which is not detoxified by the liver, which is not functioning anymore. The ammonia gets access to the astrocytes in the brain, and this is converted into glutamine, which is osmotically active, which will accumulate water. So this is the normal hepatocytes. Here, the hepatocyte has accumulated water, leading into cerebral edema. So a little bit about the Monro-Kelly doctrine. So our brain is covered with the rigid skull. So it does not have room to expand. Apart from the brain, there is CSF, arterial blood, and venous blood inside. So with that, the brain maintains the intracranial pressure around 10 to 15. Now what happens is the acute liver failure is causing brain edema, which is the extra mass here. To accommodate the increase in volume, the brain will, the CSF will go out into the spinal cord. As a result, there is compensation. But now, if we do not treat the acute liver failure, the cerebral edema will get worse. So as to compensate for that, the CSF all has gone out. Now the arterial and the venous blood is going out. When the arterial blood is not adequate enough, there will be a supply-demand imbalance. As a result, the ischemia will get worse and the cerebral edema get worse. It's kind of a vicious cycle. And at this point, the brain is also now starting to be pushed out. It cannot shrink. So as a result, it will herniate through the foramen magnum, which we call coning. So this is the point of decompensation. From that point onwards, the pressure rises very quickly. So you grade encephalopathy according to the Westhaven classification. I'm not going to go through it, just to relate this to the Monro-Kelly doctrine. So in grades 1 and 2, you have the compensation occurring that I showed you earlier. But when grade 3 and 4 of encephalopathy is there, that means your pressures are going up. It's the point of decompensation. It's the point where you should intervene, otherwise the patient will cone and die. So moving on to management. So anything managed in the ICU will be based on A, B, C, D, E. So as medics, I think you're not used to this mode, but as intensivists, we do this daily. And it helps us to keep in, so that all we do not miss any of the salient points when we are managing these patients. So we'll start with ARV. So oxygen, who needs oxygen? So any patient, not just acute liver failure, any patient who's hypoxemic will need oxygen. So hypoxemia is when the PaO2 is less than 60 millimeters mercury. And so these patients, if they are having hypoxia, you have to give oxygen. Apart from that, as a part of neuroprotection. I would explain what neuroprotection is later on. Our target saturation is 90 to 96. Do not aim beyond that point because we know hyperoxia itself can cause damage as well. So the PO2 target is 60 to 90. But if you are going for neuroprotection, our PO2 goes to about 100 millimeters mercury. This is from the Brain Trauma Foundation because we do not have specific guidelines for ALF itself. So why is this? I will explain to you. So these are the meta-analysis that's done to compare less oxygen against high oxygen, and you can see there's no mortality benefit of giving high oxygen. So don't give high oxygen to patients unless you're using neuroprotection. And how do you give this oxygen? You can use nasal prawns, face mask, and then if still your oxygen is low, instead of using CPAP, they recommend to use high flow nasal oxygen. I'm sure you have seen this. But in case where there's hypercarbia, of course, high flow nasal oxygen will not help. You will have to go for non-invasive ventilation, that is BiPAP. So then we will move on to ventilation. Who needs ventilation? So encephalopathy, grades 3 and 4, that is the point where you intubate these patients electively. I would tell you why again. And also, if the patient has low GCS with a risk of aspiration, you would intubate these patients. So a bit of physiology again. You know the cerebral blood flow is around 50 mLs per 100 grams of brain per minute, and this is about the map. The blood flow is regulated according to the MAC. This is called autoregulation. Apart from the mean arterial pressure, there are other things that would regulate your blood flow to the brain. So this is, let's look at the oxygen. You see the PO2, when it goes down, at a level of about 60, the blood flow to the brain drastically increases. So if your patient's PO2 is reduced, what will happen is the blood flow, the arterial supply will increase, which will further increase the ICP. So you have to avoid that. So in order to do that, they have recommended a cutoff of 100. That's why we said in neuroprotection, your PO2 should be 100. There's a more drastic relationship between PCO2 and your blood flow. You see at this point, it's just above and below is the normal PCO2 of 35 to 45. The moment it rises above 45, there's vasodilatation and your blood flow will increase to the brain, increasing ICP again. Also, when it's less than 35, it drastically reduces because there's vasoconstriction. That will also hamper your brain blood flow. So you do not want to have high carbon dioxide or low carbon dioxide. So in neuroprotection, our target would be around 32 to 38 millimeters mercury. Those are your two targets of oxygenation and carbon dioxide in neuroprotection. So other steps in neuroprotection in these patients would be sedation. Why do we sedate them? It's because sedation causes reduction in metabolism in the astrocytes. When there's low reduction, there would be low demand, and also the ischemia would be reduced and the cerebral edema would reduce as a result. Also, you can use paralysis, SOS. It's not a must, but sedation is a must. Also, we use a neutral head-up position. That is to ensure that your venous drainage is not hampered, and you keep it in the neutral position so your internal jugulars will not get kinked. I'll talk about hyposmolar therapy, temperature and sugar control later on. Treating seizures, yes, you have to treat seizures, but there's no rule, there's no recommendation for prophylactic seizure medication. So initially it was sodium valproate, now they have moved on to levetiracetam. Monitoring ICP. So if you insert a bolt, make a hole on your skull, insert a bolt and connect it to a manometer, you can measure the ICP. The advantage of measuring ICP is the cerebral perfusion pressure is the difference between the mean arterial pressure and the intracranial pressure. So you can actually get an idea about cerebral perfusion pressure if you know the ICP. All this time when we are only measuring MAP, you can assume the ICP, and so you have no clue about the CPP. So that is one advantage. On the other hand, in grade 3, grade 4 encephalopathy, they are at high risk of intracranial bleeds, which can be immediately identified if you have an intracranial pressure monitoring system. So in the USA, half of the patients who have acute liver failure have an ICP monitor inserted. The problem with it is because you are tampering with the brain, there can be hemorrhage due to the procedure, but they have found the risk is much less than we expect it to be. So controlled hyperventilation. So what's the role? So this is clinical trial they have done, and they have checked when the carbon dioxide is between 25 to 30, there's vasoconstriction, as I explained earlier. So this will reduce your ICP for a little time. So in patients who are coning and awaiting liver transplant, this is actually a bridging therapy. So the patient will not cone until you do your procedure. But as a long-term measure, hyperventilation is not recommended. Your carbon dioxide target is 32 to 38. Role of hyposmolar therapy. So the hyposmolar therapy is 3% sodium chloride that is available. And it is recommended to use it until your sodium is at around 145 to 155. That is the target. You use this prophylactically. That is the recommendation. On the other hand, for mannitol, there is no prophylactic use of mannitol. It is only recommended for during herniation of the brain. And but I see this often being prescribed as a regular medication, but the advantage of doing so is not being proven. And also the action of mannitol is lost beyond the point of the osmolality being 320. So if you're giving mannitol, you have to check the serum osmolality also. Remember, mannitol causes other side effects like hypovolemia and AKI. So weigh the benefits and risk before you prescribe mannitol. So then airway we have done, and we have given the targets of our airway management. So moving on to breathing. So these patients develop ARDS very quickly. So ARDS, when we do develop ARDS, the ventilation strategies we are using is according to the ARDS net protocol, which is low tidal volume and high PEEP. So the same recommendation stands here. Only issue is they do not recommend a high PEEP, because high PEEP will increase your interthoracic pressure. That's why they didn't recommend CPAP at the initial state also. The increased interthoracic pressure will hinder the venous drainage. So high PEEP is not allowed, but low tidal volume is recommended. Then moving on to circulation after breathing. So they suggest a mean arterial pressure of 65. This is based on sepsis actually. And in sepsis, they have compared low pressure versus high pressure. And the outcome, as you can see, the mortality is the same. So there's no point in achieving a high map. So you go for a map of 65. Except in chronic hypertension patients, where you might aim at a little bit high pressure because it reduces AKI, not because of the encephalopathy. Then in ICU, we do these things called advanced monitoring. I'm not sure whether you have seen this. We are inserting arterial lines, that is into the radial artery, and we are monitoring the blood pressure directly through that. So per each beat, we get a blood pressure value. So it's more precise compared to the non-invasive blood pressure monitoring. So they have actually, although it's a low quality evidence, they have recommended using this, because when you're on vasopressors and when you have a very hyperdynamic circulation, invasive monitoring helps. And also they recommend using of advanced hemodynamic monitoring. Again, if you have not worked in ICUs, you might not have seen this. We can actually monitor the cardiac output, the preload and the afterload. So they have recommended using it again, although low quality evidence. And about fluids, so the preload. What is the fluid that is recommended? It is crystalloids. So if you're able to find isotonic balanced crystalloids, it will avoid the problems of hyperchloremic metabolic acidosis leading into AKI. But saying that, we only have Hartmann's in our country, and we have some others in a little amount. If you have lactate in your fluid as the buffer, that might cause problems, because with liver failure, the lactates will go up. So in that case, we are kind of stuck with 0.9% sodium chloride. And it is recommended against use of starches and gelatin. So please do not use this in acute liver failure, or in the case of sepsis also, they are not recommended. And is there a place for albumin? Yes, there is. For resuscitation, you can use albumin. But the survival benefit is more in cirrhosis, not in acute liver failure. So there are more than enough studies showing that in cirrhotics, albumin plays a major role in reducing mortality. But when it comes to acute liver failure, we do not have studies, so we are inferring from sepsis. In sepsis, what they have shown is, when comparing albumin against crystalloids, there is no mortality overall, there is no overall mortality benefit. And also, this is a very famous study, the ALBIO study, where they compared albumin against saline. Again, there is no mortality benefit. Albumin is quite expensive, as you may know. And how much you use, it's just a small volume that comes in each bottle. So how much you use is questionable. So whether you're going to use the abundant, cost-effective crystalloids or the albumin is up to you. But my choice is usually I go for crystalloids, but at a point when I'm giving crystalloids over and over and the patient is leaking and still fluid response, I might use a little bit of albumin at that point. Vasopressors, yes. So after fluids, if the blood pressure does not pick up, there is a place for vasopressor, and the preferred vasopressor is norepinephrine. They have compared this again and again with dopamine and epinephrine, and as you can see, there is a mortality benefit of epinephrine over dopamine, and even epinephrine, because they have more side effects because of their inotropic effect as well. Then there is a suggestion to add low dose vasopressin. So when they actually explain it, when the norepinephrine dose goes to or above 0.25 mics per kg per minute, to add vasopressin. This is a low threshold. So acute liver failure has a low threshold to start vasopressin. And here they have compared in this meta-analysis vasopressin with catecholamines against catecholamines alone. And there is a mortality benefit of adding vasopressin. So that's why we are adding vasopressin here. So you have maintained your preload, afterload, and contractility. Again, if you're having problems with contractility, there's a place for dobutamine, but they have not made a recommendation on the guidelines. So I have not mentioned it. Now we move on to dysfunction, which is your brain. So now the brain is encephalopathic, so you have to protect the brain. And sugar is one of the agents that cause more damage. So our aim is to maintain our sugars around 110 to 180 using soluble insulin as an algorithm. We do not go for long-acting insulins, and we do not go for tighter control because hypoglycemia itself can cause more brain damage. The role of lactulose. I consider lactulose as mainly of a drug that is used in the ward setting rather than in the ICU, especially in higher grades of encephalopathy. The value of lactulose is not that great. And you can use it in the ICU also, but not to the point where it causes diarrhea. And they have actually said, like, if you're going for a liver transplant, it may hinder your surgical site by causing a bowel distension. So lactulose, low quality evidence for use in acute liver failure. Lola, again, no point, there's no recommendation for use in acute liver failure, maybe in chronic, but not in acute liver failure. As you can see, there's no mortality benefit of using Lola. Use of barbiturates. This is thiopentone and phenobarbital. They have the ability to stop the metabolism completely in the astrocyte. Thereby, you're reducing the demand from the brain. So if your patient is coning and is awaiting liver transplant, you can actually cause a barbiturate coma and stop the metabolism completely. And when you with the use of barbiturates, you can see the ICP drastically goes down, but at the expense of a reduction in CPP also. You can see the cerebral perfusion pressure goes down because these cause cardiac inhibition as well. So you have to be cautious when using barbiturates, but there is a recommendation for its use. So with that, the encephalopathy we have managed. So we move on to E, which is everything else. Control of infections. So infection is kind of the second killer in acute liver failure. These patients, as I said earlier, are very prone to get infections because their immunity is suppressed now. But saying that, they do not have a recommendation for prophylactic use of antibiotics or antifungals. Instead, they make recommendations of regular surveillance. Send your cultures, your biochemical markers. But if you really suspect that there's an infection, use antibiotics. They have not recommended any antibiotic over the other. It's according to the local guideline that you can use antibiotics. Clotting abnormalities. So everybody is worried about the INR, which most of the time is non-readable on your biochemistry, on your hematology. And but what they say is go with your viscoelastic testing rather than going with your conventional PT-INR, fibrinogen, or the platelet counts. That is for daily use of blood products as well as before procedures. You're afraid to insert the arterial line or the central line or the bolt. So if you're doing a procedure, you go for a viscoelastic testing rather than correcting the INR. So there's no recommendation to correct the INR. So what happens in normal coagulation? The coagulating factors will form the clot. And as you can see, the thrombin concentration goes up very drastically. But in a little while, your anti-clotting system starts working up and it will break down the thrombin. And as a result, there will be no bleeding as well as no thrombosis. So there is a balance. But what happens in the PT-INR test? Usually factors 5 and 8 gets activated through this cascade, and there is an anti-clotting factor that is involved, thrombomodulin, which is not added as a reagent in this INR test. So obviously these 5, 8 will go down because your liver is failing, but the thrombomodulin is also going down, which is not being measured through your test. So INR is high, but also your anti-clotting is also high. So if you look at in detail of all the clotting things that happen, it's kind of a haywire. Everything is like deranged. Your anti-hemostatic drivers as well as your pro-hemostatic drivers are haywire. They are all over the place, but they ultimately reach this paper-thin balance. So your patient will not bleed. Actually, there is a high chance of thrombosis in these patients. So it is not wise to use FFP unnecessarily. So they have done this randomized control trial where they have compared thromboelastography, that is the TEG and the ROTAM, against conventional testing. And what they have found is, with use of the TEG, the overall blood product requirement is significantly less. And also the overall FFP use is significantly less. And if you can look at the mortality, it's the same. So that is the recommendation: use your viscoelastic testing. The hemoglobin target for acute liver failure is 7, unless there are other indications for having a different hemoglobin value. And here again, this is in cirrhotics, not in acute liver failure. They have found if you have going for a restrictive strategy, that is hemoglobin of 7 rather than some liberal, which is hemoglobin of 10, your mortality is actually less. So it favors, there's a survival benefit. Even post-liver transplant, the survival is better if you're using less red cells. So less transfusion, better the outcome. There's no recommendation for thromboprophylaxis for acute liver failure at the moment. And role of extracorporeal system. So if there was another machine that could do the functions of the liver, that is mainly detoxification, that would be useful theoretically. And there are machines like the Prometheus, the SLAD, they have made in the Western world, and they have used it, and they are functioning well, but at the cost of very high financial burden as well as labor that is being used for. So whether it is actually cost effective is questionable. So actually even these high capacity liver centers are not using these extracorporeal systems as much as we think they are. But of course, plasma exchange, high volume plasmapheresis has a role, because repeatedly in these trials, they have shown that plasmapheresis reduces the ammonia levels, which is the culprit, and also they increase the liver transplant free survival. So there is a survival benefit in using plasma exchange in acute liver failure. Renal support, they suggest using renal replacement therapy early in patients who develop acute kidney injury on top of the acute liver failure. And here is the comparison of ammonia levels in with CRRT, that is continuous renal replacement therapy, against without renal replacement therapy, against intermittent renal replacement therapy. So the drop in ammonia is more with CRRT. So in acute liver failure, the modality would be more towards CRRT. And also, post-operatively, liver transplant patients who have acute kidney injury have high mortality compared to patients who do not have that. And even in these patients, use of CRRT early will reduce their mortality. Okay, then moving on to steroids. Is there a place for steroids in acute liver failure? Yes, there is. But this is only during shock. So this is the septic recommendation that we are using here. So if you're going up on your noradrenaline and you're adding vasopressin, it is at this point that you start your IV hydrocortisone 200 milligrams daily as an infusion or as a intermittent bolusing. So there are more than enough trials in sepsis. Here the VANISH trial, the adrenal and the APOCUS trial, which actually have shown that it reduces the shock. You can come down on your catecholamines quite quickly if you use steroids, and the mechanical ventilation and the length of stay is reduced by using of steroids. And there's improved mortality in this study. But does it actually, are there other indicators of steroids in acute liver failure? Does it reduce cerebral edema? Because we have seen that it is being used constantly in cerebral edema. This double-blind randomized trial, there are more. I just chose one. Ultimately, their conclusion was corticosteroids should not be used to control elevated ICP in patients with acute liver failure. There are instances like for a SOL or some infections where you would use steroids to reduce the edema, but definitely not in acute liver failure where there is diffuse cerebral edema. There's no place for steroids. Nutrition. There was this thought of using low proteins, but that is, they have gone against it. You have to actually go for high or normal protein, 1.2 to 2 gram protein per kilogram weight per day. when it comes for proteins, and they have actually shown the worry was that it increases ammonia level, but in this study they have actually shown the ammonia level is less compared to patients who are not being given proteins. It's significantly less. So you have to continuously feed these patients with normal or high protein levels. And also there was a concern about branch chain amino acids over aromatic amino acids. There is no suggestion or recommendation to use one over the other. You can use whatever protein that is available. And also they make a recommendation of early enteral nutrition. As Professor Hidalgo earlier explained, your microbiome, now it's an emerging field in critical care medicine. So in order to maintain that microbiome and other benefits, you have to start enteral nutrition over other types of nutrition early as possible. Do not keep your patients nil by mouth. So specific therapy, I think y'all can teach me because y'all the medics, I'm just the intensivist. But so I'm not going to go through this. Anyway, I don't have time to go through this. So well, ultimately what happens in liver failure is your liver is having necrosis on one side and it's regenerating on the other side, and ultimately it will recover. So that time period it takes to recover is the period that we are supporting the patient organ-wise, A, B, C, D, E-wise, so that the patient will not die within that time period. Also, your specific management will help that liver to regenerate. Saying that, only 50% of your livers will regenerate to a level that the patient will survive. The rest of the 50% will die if they do not have a liver transplant. So prognostication and liver transplantation. So it is crucial to have a reliable, credible prognosticate model to identify patients who will die without a liver transplant. This is to avoid unnecessary liver transplantation in an era where we do not have enough organs to transplant, and also where we are pressurizing patients with long-term immunosuppression. So whatever the prognostic model is used should identify the perfect patient to undergo a liver transplant. So up to now, the best model that we have that is validated is the King's College criteria, which has high sensitivity, high specificity, as well as a high positive predictive value. So ultimately, the outcome of these patients, so as I said, 50% will recover with the supportive treatment itself, and 24% will recover with transplant, 28% will die because they did not have transplant due to some other reason. So what about Sri Lanka? Unfortunately, we do not have data on our acute liver failure patients in the country. But I have been, in my ICU, the medical ICU in Ragama Hospital, I have witnessed about 6 patients per year of acute liver failure. This is acute liver failure, not decompensated liver failures. And this is could be because we are a liver center. We are getting referrals from other places. And 4 of them actually needed a liver transplant, but they died because they did not get a liver transplant done. Why is this? Because we do not have a proper transplant program in the country. So cadaveric transplant is the way to go in adults, but unfortunately our transplant program is not supported enough so that we get enough organs for these patients. Saying that, we have one patient of all the patients who had a liver transplant done in acute liver failure. This is the only patient who survived after acute liver failure, after a cadaveric liver transplant. And I thought this is after permission to post a picture of her. This is 1 year after the liver transplant. Looking on the bright side, we have a very good pediatric liver transplant program. So a very good team at Ragama. And so 7 patients up to now had acute liver failure. 4 of them had transplants. So why the high rate of transplant in pediatric? It's because it's a living donor. Their mothers or someone related gives the liver to them. So that's easier. The logistics are easier. So again, with permission, so these are the kids that came after the liver transplant. This is the youngest. He's 9 months during this transplant. So I asked my hepatologist at Ragama and the surgeon, what is the message that you want to give to the physicians who are listening here? And they said, to involve in acute, if you get a patient in acute liver failure, get your hepatologist involved early and refer to the liver transplant center if it is warranted as soon as possible, rather than medically managing them over and over. So with that, actually, I have come to the end of my talk. So any questions?
Thank you, Anushka. That's wonderful, informative lecture. I think, yeah, will physically anybody want to, who are present here in the audience, want to ask any questions? Yeah, wait for the mic. Yeah.
Hi. Thank you very much for your nice presentation. What were the causes for the acute liver failure in Sri Lanka in these 6 and 7 patients?
Most of them, the youngest one had and Wilson's is the main. It's the first presentation of Wilson's. It's not chronic. It's not chronic liver disease. It's Wilson's, the first presentation. And some of the patients who died actually had I think it was broadcasted on TV also, the paracetamol overdose, which was not transferred to our hospital, but it's mainly Wilson's. But for more detailed account of the etiologies and all, I would like to talk to Miranti, our hepatologist, pediatric hepatologist. She's the one who takes care of the acute liver failures preoperatively and postoperatively also. Exciting.
Any more questions?
Oh. Thank you.
Anushka, I have a question now. In the West, you say it's paracetamol overdose is quite common. Now we see quite often patients come with paracetamol overdose to us and units. What do you think the difference? Why they don't either paracetamol is not working, or why is there any reason?
It's kind of a philosophical question, I think. Why we are not overdosing ourselves with paracetamol? Yes. Actually, I don't know why. Do you know, Dilshan? I'm not sure why we are not overdosing ourselves. But as you said, the frequency of paracetamol overdosing is increasing in the country. But as I said, the etiology, paracetamol has a favorable outcome. So they do not end up in liver transplant centers or going into liver transplant. They recover usually. But why the numbers are high, I'm not sure.
And the other thing about the fluid management, now we, the sepsis and liver behave similarly. And, if you don't have any advanced, tools to monitor the cardiac output and all, would you like to recommend something for the general physicians, when you are, they will be quite fluid responsive in the initial stages in it. Do you have any thoughts or comments on how you go about your fluids in the initial stages?
Yeah, initially in septic shock anyway, so this applies to acute liver failure also. The initial 30 ml per kg bolus is irrespective of the fluid status of the body. So you can use that initial resuscitation fluid without having any concerns about your fluid status. Afterwards, of course, then you will have to go for your clinical parameters. I think your heart rate, your blood pressure, the peripheries, the capillary refilling time is a very good indicator. The Andromeda trial has shown that it is comparable to other invasive cardiac output monitors. So you can go with those, and your urine output. So use a multitude of parameters rather than going with one. And also you can use the ultrasound. Although IVC is not validated as a good fluid responsive monitor, you can get a basic idea. You can go with the trend of your IVC if you have an ultrasound in your board. Apart from that, if you are trained in doing echoes, if you have an ultrasound and if you have an echo probe, you can look at the ejection fraction or the VTI on your left ventricle, which again would increase with the fluid bolus. Those are the things that I think you can use in the ward setting.
And what about the lactate? Now the lactate can go up even in liver failure. So would it help with your fluid management, or you just have a thought this could be coming from the liver as well?
So in sepsis especially, they have recommended against using lactate as a sole predictor of fluid responsiveness. You can again add it with your other parameters. Don't go with just as a single parameter. And because it lags behind your fluid management. And in liver, the problem is the lactate in liver failure doesn't go up because your perfusion is poor. It's because the liver is unable to metabolize the lactate. So there is going to be a question whether after fluid bolus your lactate doesn't go down, whether it is due to reduced fluids or whether it's due to the liver failure itself is questionable. So I don't think you can go by your lactate. Lactate is more of a prognosticator for the liver injury rather than the fluid in liver failure.
Thank you, Anushka.
Thanks.
Thank you, Anushka. Just we have a certificate of appreciation on behalf of the college. Please accept additional due ledger.
Next, we have a case-based discussion, which is the most interesting part, I believe. So for that, we have two speakers to introduce Dr. Lilanti Samara Subasinghe, who is a consultant intensivist at the University Hospital of Sir John Kotlawala Defence University, Virahara, and Lilanti is a proud product of Faculty Medicine University of Colombo, and she is our current secretary at the College of Ceylon College of Critical Care Specialists. And so with her, we have Dr. Kanita Jaya, who is the senior registrar in critical care medicine, who is going to talk to us on a very interesting case where we managed in one of our ICUs. So we would like to hand our table to you to carry on with your talk.
Thank you, Ceylon College of Physicians, for giving us the opportunity to discuss this case in today's forum. So let's go straight to the case. So today we are speaking about a 63-year-old male who had no previous comorbidities as up to then, and he was a non-smoker and a teetotaler. He presented with progressive difficulty in walking associated with upper and lower limb numbness, which had worsened over one day. There was no facial or bulbar weakness or any bladder or bowel involvement, and on examination, there was bilateral flaccid paralysis, more in the lower limbs compared to the upper limbs, with globally absent reflexes, without any objective sensory loss. The rest of the systemic examination didn't show any findings of note, except in the cardiovascular system, where there was a sinus tachycardia of around 100 beats per minute and an elevated blood pressure of around 180/90. So this was how he presented to the ward. So a clinical diagnosis of Guillain-Barré syndrome was made, and it was supported by nerve conduction studies done, which showed acute neuropathy suggestive of AIDP, and a lumbar puncture done on day 7 of the illness showed cytoprotic dissociation. But pending the lumbar puncture, he was started on definitive management. The rest of the initial investigations did not show any significant abnormalities. His renal functions and his ECG, all of those were normal. So initially, as I mentioned, he was started on definitive management with IV immunoglobulins, 0.4 milligrams per kg dose for 5 days. The high blood pressure was controlled with oral antihypertensives. Thromboprophylaxis with subcutaneous enoxaparin was started, and his cardiovascular and respiratory parameters were closely monitored, including single breath counts. So, around 1 week after the initiation of the therapy, he still did not show any significant improvement of his motor power. And yet, there was no new onset, any other neurological signs either, and no significant respiratory muscle involvement. Then a decision was taken whether to go for a second modality of treatment, and therapeutic plasma exchange was considered. Then, around day 10 of his ward stay, the patient developed a new onset difficulty in breathing. There was no significant chest pain of the ischemic or pleuritic type variety, and there was no significant cough or hemoptysis as such. There were some new onset fever spikes with some rise in inflammatory markers as well. On examination, he was febrile, and his respiratory efforts had deteriorated with a single breath count now around 16. And there was mainly bilateral fine crepitations in the lung bases with some interspersed coarse creps as well. His tachycardia had worsened, and it was now in the range of around 150 beats per minute, still sinus tachycardia, and the blood pressures dropped from 180/90 to around 80/50. So this was the ECG taken at the initial presentation, and I think you can appreciate that there is extensive ST elevations in the anterolateral leads. So this was the ABG done because those were the first investigations we do when a patient deteriorates. So as you can appreciate, he has a acidosis which is of a mixed kind with a metabolic as well as a respiratory component, and elevated lactate levels slightly as well. So seeing that this patient deteriorated very suddenly, he was electively intubated in the ward, sedated and ventilated via the portable ventilator. IV noradrenaline infusion was started to maintain his blood pressure, and due to the ECG changes, the patient was started on stat doses of antiplatelets as well as enoxaparin, and the patient was then referred to the ICU outreach team. So the outreach team went to the ward, and then we assessed him in the ABCDE manner. So at that point of time, he was intubated and ventilated and maintaining a saturation of around 94% with an FiO2 of 70%. And still on examination, there were bibasal fine crepes, and a chest X-ray was not available at that point of time, so it was ordered. Blood pressure had now stabilized to around 140/100 mercury millimeters. The tachycardia had slightly reduced, but he was still on the noradrenaline infusion. Blood was also sent for some basic investigations. He was sedated with IV midazolam, so GCS, but showed spontaneous eye opening with some motor component, though, was around 3 out of 6, due to mainly contributed by the fact that he had diminished muscle power, and he was intubated, so verbal response was not assessed. Blood sugars were within the normal range. He was febrile, and he had a poor hand grip. So I would like to ask the audience, what would you think could be the causes for his sudden deterioration in the ward?
Anyone in the crowd would like to answer the question, or what do you think it is? So if I may sum up the patient, he was acutely deteriorated with tachypnea, and he was febrile with rising inflammatory markers. However, we showed you the immediate ECG we took upon him, and he was with fluctuating blood pressures. However, more or less, he was in a shocked state when we saw him, and he needed invasive ventilation immediately following his acute deterioration. So we thought of few differential diagnoses, starting with a hospital-acquired pneumonia possibility, the first possibility, going into sepsis and septic shock. Mind you that this patient had been in the ward for a good 10-12 days. So he would have jolly well acquired the hospital-acquired infection, going into septic shock and this cardiac event. And at the same time, we thought of a PO, acute coronary syndrome, and occlusive MI as well. You saw the ECG, right? So it could well be an obstructive occlusive MI as well. And due to the fact that he was weak and he was on the bed for a long period in the ward without sort of mobilization actively, we thought of a pulmonary embolism as the third option. And we didn't forget about the ascending paralysis due to the Guillain-Barré involving his respiratory muscles, which would give rise to this mixed sort of a respiratory failure at day 10 of deterioration. So what did we do? We took the patient over to the ICU for ventilatory support. Obviously, he was intubated at the time we saw him, and for close monitoring of his hemodynamics. So this brings us to the concept of critical care outreach teams. I hope you would have seen it functioning at least partly here in the NHSL at least. So they are similar to the rapid response teams and MET teams we find respectively in USA and Australia. You would have heard about them, and they are generally nurse-led. The teams comprise of doctors and nurses, and their main role is to identify deteriorating patients out of the ICU in the ward setup, which is very important in catching these patients up early and presenting them to the ICU for a timely intervention, timely admissions. At the same time, it avoids unnecessary admissions to the ICU because we have a very limited ICU bed capacity. So this patient had that chance of being assessed by the outreach team very quickly. As well, these teams enable discharges from the ICU because we find it difficult to follow up these patients once we discharge from the ICU. So they go to the wards, they help the ward staff in assessing these patients on a daily basis, and then they discharge from that list also. So apart from that, they empower the healthcare staff in the ward setup by teaching and training them in ward-based critical care skills. So this brings us to the point to discuss about who needs ICU admissions in Guillain-Barré syndrome. Now, if you see on to the left hand of the slide, the main indications for ICU admissions in Guillain-Barré would be respiratory causes. The trend of deterioration of their respiratory effort is the main cause, leading to endotracheal intubation. So you need to monitor them subjectively as well as objectively. And on the right side of this slide, you may see a score which was brought up by the study below, which is the Erasmus GBS respiratory insufficiency score, which can help us in objectively assessing these patients' efforts. Apart from that, hemodynamically, if they go into dysautonomia, leading to severe fluctuations of their hemodynamics, blood pressures, heart rates, which can go into some sort of a shock, mainly we don't know, they can acquire a cardiogenic shock due to dysautonomia. So these things are the main indications for ICU admissions. So if you appreciate the box here, these are the numbers we look into when we take up a Guillain-Barré syndrome patient to our wards prior to intubation. If the patient, unlike with this case, if the patient is not intubated, we monitor in a similar way as you do in the medical ward. The forced vital capacity, which would give rise to the effort, which would let you know about the efforts of the patient, how strong the efforts are. So the forced vital capacity and the oxygenation level and the carbon dioxide status, which can again give us an idea about their type 1 or whether they are going into type 1 or 2 failures. And the most important thing is that you need to monitor these closely to see the trend of deterioration so you can act upon quickly. Apart from these indications, if you can appreciate these ones here, airway obstruction and what I discussed, the autonomic disturbance, because they can go into bulbar palsy and they can develop a lot of secretions as well as part of their primary disease. So these two are again another indication for ICU admission. So when we assess the patients, we can decide whether they are okay with non-invasive or whether we need intubation. Right, so what did we do on admission, Kanita?
Yes, so we transferred the patient to the ICU soon as possible, and then once more he was reassessed from airway, breathing and circulation and so on. He was connected to the ventilator and ventilated via the SIMV mode with an FiO2 starting with around 60% and PEEP set at around 6 mercury millimeters and inspiratory pressures of 80. His ventilation was managed, but his cardiovascular system showed the most instability at that point of time. There were drastic blood pressure fluctuations, with systole changing from around 150 beats per millimeters mercury to 50 millimeters mercury within very short times. So he was started on hemodynamic support with iron pressors, which we had to gradually escalate, starting with noradrenaline and adding on adrenaline and dobutamine as well via a central venous line. And to monitor these rapidly fluctuating hemodynamic parameters, we inserted a radial arterial line and monitored his invasive blood pressure, as well as since the suspicion of sepsis was there, we obtained blood cultures and started him on antibiotics as well. So we basically managed his shock. This was his ABG, and you could see the oxygenation parameters have slightly improved, but with a PF ratio of still around 163, and lactate had risen a little bit more than what was in the ward, and he still had mainly a metabolic acidosis. So what would be the next step that we can do in an ICU to maybe differentiate these various kinds of shock as in this our patient, madam?
Yeah, so as a habit of daily assessment, we tend to go for this, which is the focused intensive care echocardiogram. It's one of the important methods we use bedside in all of our patients very frequently, and it can give us a lot of information, especially in categorizing the shock, the type of shock they're having. So they can FICE can assess the left ventricular function, the right ventricular function, evidence of any massive pulmonary embolism, the fluid status of the patient, as well any pericardial disease giving rise to obstructive shock. And at the same time, you can get an eyeballed idea about the fluid status of the patient when you assess the IVC as well as the lung basis, which can give you an idea about the wetness of the lung. So these were the images we obtained in our patient. These are true images we obtained from our patients. So the first one, which is the apical long axis wave, parasternal long axis wave onto your, this is your left ventricle, if you can appreciate. It shows reduced level of contraction. And if you see this image over here, it is the short axis wave. Again, there is, I'm not sure whether you can appreciate, but it is very much reduced, the EF at the papillary muscle level. If you can see this image down there, where we have visualized the IVC, it's sort of full. It doesn't show any collapsibility, which would otherwise give you an idea about the fluid responsiveness about the patient. The last image over here is the lung basis. It's not that clear, but you can't appreciate any massive pleural effusions or any consolidation in the base. So this was what we did afterwards.
So a diagnosis of ST elevation MI in the background of severe dysautonomia in Guillain-Barré syndrome was made, and the patient, after liaising with the cardiology team, the patient was transported to the cardiology unit for an urgent coronary angiogram.
Right, so transporting a critically ill patient from one place to another. There are lots of aspects we have to look into. I'm sure as medical registrars or medical doctors, you would have done it several times, but there's a proper way to do this. We all have to know that there are lots of aspects to look into in this aspect. The mode of transfer. So this was an intra-hospital transfer within the hospital, but had a long way to go to the cardiology. And then coordination between the dispatching and the receiving teams, it's very important. You have to communicate with the senior most person and tell that the patient is coming. The timings are very important. And the pre-transfer assessment, do you do that in the wards? We have to do it at least shortly. We have to prepare the patient. We have to see his baseline parameters on the time of dispatching. Monitoring should be continuing throughout the transfer and back where he belonged to, because most of the time we get the patient back. Equipment and drugs, we need to make sure everything is right and enough for the transfer and the way back. The personnel, the trained personnel, the nurses and the doctors, especially airway trained doctors, are needed for this. So you have to do the transport very, very safe, in a very safe manner. And post-transport care has to be decided preemptively whether it is being done by us or the receiving team. So there had been guidelines laid on this. So this is not a simple matter. You need to take it very seriously.
So now you can see 3 views that we obtained in this patient's coronary angiogram. I'll play them for you. So the right coronary view, the epicranial view, and the spider view. So keeping in mind that this patient had significant ST elevations in his ECG and was in shock, and looking at these angiographic views, any comments that you would like to make?
So these images, with respect to the gravity of the shock he had, did not reveal any major vascular abnormalities or any feature suggestive of an occlusive MI in any of the trees. And then we had to opt to another view. What was that, Konita?
So we went with the So this is the view, and I think you can appreciate the apical ballooning seen in this view. So our final diagnosis was the patient with minor coronary artery disease with mid-segment Takotsubo cardiomyopathy in the background of severe dysautonomia in Guillain-Barré syndrome.
Right. So I'm sure the crowd knows about Takotsubo more than us. And what we find in the ICU is mostly the secondary form of it. We find, at least in theory, but we have seen a lot of Takotsubo within the ICU because of these secondary causes. So I would like to highlight few of these. So this patient of ours had autonomic instability. So that is one of the main causes of Takotsubo. And if you can appreciate the neurologic disorders, we see a lot of Takotsubo in neurologic patients when they have a head insult, for example, subarachnoids, acute obstructive hydrocephalus, for example, in colloid cyst patients, as well if they go into severe sepsis, infections, if you can appreciate the other causes, post-surgical. So we see a lot of Takotsubo in a mixed ICU. How do you manage Takotsubo in the ICU? You have to treat the underlying cause if applicable. So ours was the dysautonomia due to Guillain-Barré. So we had to manage that. We had to decide whether to go for the second IVIG or the PLEX. Anticoagulation should be offered short-term for the classic pattern of apical ballooning because they have a higher risk of akinetic apex leading to thrombosis. Arrhythmia management would be as in any other patient. You need to follow the usual protocols, and further management depends on the hemodynamic stability. If they are stable, you can go for tachycardia control. However, if they are unstable, to select on the pressors or the inotropes, you need to see if the patient is having a left ventricular obstruction. So this patient, we used the first few. He was more or less stable with the inopressors. So this is what we did afterwards.
Yes. So, owing to the severe dysautonomia, we had to deeply sedate the patient and ventilate him for a considerable number of days. And the hemodynamic monitoring was continued with clinical parameters as well as our invasive blood pressure monitoring, as well as IVC and focused echocardiographic assessments. Blood pressure, as I said, was maintained with 3 inopressors and gradually tailed off. Fluid intake was titrated again to maintain a negative balance. Early feeding was started, enteral feeding was started via an nasogastric tube. Enoxaparin was initially given at a therapeutic dose but later reduced to a prophylactic dose. Stress ulcer prophylaxis and other supportive managements such as blood sugar control and screening for sepsis and appropriate antibiotic therapy was started in this patient. So this patient's primary problem in the ICU was the severe dysautonomia, and in our patient it manifested with this Takotsubo cardiomyopathy and the acute left ventricular failure and the severe shock requiring multiple vasopressors and inotropes and persistent tachycardia with some episodes of bradycardia in between. And by the time we started mobilizing the patient, he had severe orthostatic hypertension as well. So as we said, we managed him with close monitoring and titrating of his vasopressors and inotropic drugs. And then we had to go for a definitive management. And in his case, we went ahead with therapeutic plasma exchange. And the supportive therapy was given for the heart failure and the tachycardia.
Okay, so this brings us to the general intensive care management of a Guillain-Barré syndrome patient. I'm not sure whether you can see it clearly, but divides into three main arms. First, we should select the standard treatment. When this patient came to us, he has had one course of IVIG. So we had to select what specific treatment we need to go ahead. So for this, we had a lot of MDT discussions with the neurology team. And we had selected one form. As Kanita said, it was therapeutic plex. ICU monitoring involved almost all of his systems. So we were very meticulously observing him, his hemodynamics and respiratory status, and general intensive care focused for a Guillain-Barré syndrome patient. As he recovered, assisted cough, proper nutritional support, his avoiding infections, avoiding DVTs. These were our main aims in managing this patient. So just a recap of what they can have, just what this study shows is that they can have almost all the systems involved in the dysautonomic spectrum. So any specific management for dysautonomia? No. So optimal treatment is not well studied. We don't know what we can give specifically. Both can be used with equal efficacy. So how did we ventilate this patient? These two explanations I have explained before, how we decide on intubation, but I would like to focus on this part. So they usually need mandatory mode in ventilating. So this patient was in SIMV because they can't trigger their breaths initially. Once they start recovering, they could show us their spontaneous breaths so that we can start weaning. So usually we don't wean them until the vital capacity improves. Often they require long period of ventilation, weeks and months. Many need intubation very early in their illness, and many of them go for early tracheostomy because the predicted period of weakness is lengthy. As well, they can experience very slow respiratory wean. So keeping these in mind, we were preemptively expecting problems in this patient. So this was done.
Yes. So patient in view of his severe dysautonomia and the poor muscle recovery, we went for a therapeutic plasma exchange 5 cycles. And then, Madam, would you like to explain how we chose between the two modalities?
Yeah, so as I explained earlier, we had a lot of MDT discussions. So just to recap on what they are for, the IVIG, it is the usual treatment we give as first line, but plasma exchange also have an equal benefit as the first line treatment. So this slide just sums up the comparison between the two arms of treatment. In terms of its mechanism, efficacy, both have advantages and disadvantages on their own and complications as well. The cost, if I can just recap, this study has shown higher cost in PE. Obviously, we can't afford much plex in our country at this point of time also. So how did we attain to this decision of going for plex? So these were our data and evidence we had. These were what we discussed in our MDTs. There was no additional benefit on both also as co-therapy. They don't have any sort of, they showed that they had similar efficacy in managing GBS as a primary or secondary treatment both. There is no place for steroids, all of us know that. And there are no proper studies done to evaluate the role of plex as well, alone in the management of a poor response patients as we suspected in our patient as well. So we offered plex. Did he recover? Let's see.
Yes. So initially, with the our main concerns were his dysautonomia and his poor muscle recovery. We initiated specific therapy and supportive therapy, but like most people know, Guillain-Barré syndrome has a long protracted course, and that was the same in our patient. So with the longer ICU stay, further problems came up. So this is just a summary of some of the investigations. Mind you, he was in the ICU for a total of around 34 days. So initially, his renal functions were in the normal range, but he developed an AKI while in the ICU, as well as inflammatory markers and white cell counts. You can see there was a rise. So he developed several episodes of sepsis as well. So this is his X-ray. There is pulmonary edema. And this is his fever chart. So you can see that he had several fever spikes. Initially, some of the fever could have been attributed to the dysautonomia also, but later he developed several episodes of sepsis. So, as I said, the AKI required renal replacement therapy, and due to his hemodynamic instability, we went with 4 cycles of SLED, and the episodes of sepsis were multifactorial. There was initially he had a hospital-acquired pneumonia, but later developed ventilator-associated pneumonia with Acinetobacter positivity, and 1 or 2 episodes of catheter-related bloodstream infections because of his indwelling central venous lines as well as vascular dialysis catheters. So, as Madam mentioned, we anticipated the prolonged ICU stay, and he underwent a tracheostomy on ICU day 9 and was being ventilated. So, the next main issue that we got was the difficulty in weaning him from mechanical ventilation. So in his case, the poor muscle power, yes, there was slow recovery from Guillain-Barré, but also then comes into the picture the presence of ICU-acquired weakness, so concomitant ICU-acquired weakness. Then, as I showed you the fever charts, he developed recurrent episodes of ventilator-associated pneumonia. He had cardiac dysfunction as well as renal dysfunction leading to some degree of fluid overload, and he had to be sedated for a longer period of time due to his autonomic dysfunction as well as due to the mechanical ventilation per se. So with all of this, his weaning became difficult. So ICU-acquired weakness, once again, the management is supportive. So we tried to omit sedation as soon as possible, as early as possible. We gave him initial sedation holds, and once he was on a tracheostomy and the dysautonomia settled, we were able to omit the sedation. The vasoactive agents were tailed off as soon as his blood pressure stabilized. Measures for prevention as well as prompt detection and treatment of his ventilator-associated pneumonias were taken. Adequate nutrition. We started early enteral nutrition, initially via NG tube and later via PEG tube once we got that inserted. And macro and micronutrient supplementation was given special concern. And blood sugars were controlled with IV insulin, and regular thrice a day limb physiotherapy as well as chest physiotherapy was given. And once he was able to mobilize, we started mobilizing him on the bed and then onto the chair as well. So, yes, Madam.
So yes, so you would have seen in the last crowded slide of Kanita how much of a battle we play in the ICU. It's not just treating the Guillain-Barré, it's just preventing your complications. It's a huge battle in the ICU. You need to make sure that everything is in place, and the team plays a big role, not just the consultant or the medical officer. The whole team, including the nurses, play a big role. So what is this ICU-acquired weakness which ultimately ended up in difficulty in weaning in this patient? It is clinical weakness acquired in a critically ill patient, more or less a diagnosis of exclusion. It is directly attributable to their critical care stay. So there are 3 types: neuropathy, myopathy, and the mixed picture. So there's a whole spectrum of this acquired weakness. It starts at least 1 week after the onset or the ICU admission, and it affects very adversely in the short and long-term outcomes of patients, even though they recover from the primary illness. There are no effective treatments, but wherever possible, you need to prevent it. So that's what everything Kanita talked about, everything she talked about are considered as trigger factors: the drugs, the sedation you give, the neuromuscular blockage, your sugar control, avoiding specific drugs like steroids. They play a big role in avoiding this cumbersome complication. So all these are the factors contributing to ICU-acquired weakness. How do we diagnose? So it's an exclusion. It's following the exclusion of other possible causes. So we need to do a battery of investigations to exclude other possible causes. So this patient, we had a concomitant cause for his weakness. It could be slow recovery from the GBS, but we really can't. What else can we offer? So definitive could be neurophysiological investigations, including the nerve conduction studies, the EMG, which was not plausible in this patient, and even muscle biopsy when there is diagnostic uncertainty. But we didn't go ahead with all of these because the management doesn't change much with whatever you get, that's the result. So as Kwanita said, all of this we did, and we needed to get this patient out of the ICU. So how did we do it? We need to wean from the ventilator and extubate him for him to go back home. So this is the general weaning protocol of an ICU patient, not just Guillain-Barré. So we go along this path to any of the intensive care admissions who is needing invasive ventilation. We daily assess for the possibility of the patient's spontaneous breathing. So we do daily spontaneous breathing trials. We start this once the indication for intubation has resolved, and we are confident that we have treated the primary cause for his intubation. We need to check the clinical stability, his hemodynamic parameters, and whether he's having good mentation, how is his GCS, whether he can follow our commands. His oxygenation, these parameters, his saturation, how much of oxygen he's needing, and the PF ratio, his oxygenation level, the amount of PEEP he needs, and as well the ventilatory function in these parameters. So once the patient is ready, we give him a spontaneous trial of about 30 to 120 minutes. So it's proven that it's enough for 30 minutes of CPAP on its own. If the patient is successful, we can go for a trial of failure. What if he fails? So he goes this round again and again in the ICU. This is what we call the weaning failure. He goes again in this cycle. We rest him, again try this. So it's a very, very hardy job for the ICU staff as well as the patient. So this study was the biggest study I could find, which was done on ICU patients on Guillain-Barré. It was done in the UK, involving 29 patients. So you can see how much of a burden which needed prolonged ventilation. So I would like to draw your attention to these two factors. The time from intubation to decannulation of their tracheostomies, which were done early in the course. The average days was 193 days, which is a quite long run. As well, bridge to weaning using nocturnal NIV. Most of them, nearing 60%, needed nocturnal non-invasive ventilation as a part of their weaning. So this, can we do it in our country? It's very time-consuming, labor-consuming, as well as costly. So the same study, if you can appreciate these facts, 7 patients were not weaned at all from invasive ventilation. And 3 patients still requiring ongoing non-invasive, even though they were decannulated as well. So there had been instances that they even needed prolonged periods of ventilation. So what could be the causes? So we had to sort our patient. So this study, the same study, had revealed several causes, deaths related to critical illness itself, the VAPS Karnitha was talking about, and then vocal cord palsies, which can give rise to difficulty in getting the tracheostomy out, and atypical presentations. This we didn't forget, the continuation of Guillain-Barré. So ultimately, we found the solution. He was sort of ready to go home.
Yes. So in our patient, finally he was transferred out of the ICU on ICU day 34. His tracheostomy was decannulated around day 24 or 25 of his ICU stay. Solving assessment was done, and we were able to start him on oral feeds and remove the PEG tube before sending him out of the ICU. He was off antibiotics for about almost the last week or 2 of his ICU stay. We were able to keep the infections at bay. His muscle power did improve, but not to the pre-morbid level, but he was able to mobilize to a chair. And patient received further in hospital treatment for about another 2 weeks, and then he was discharged home. So just a video of the focused echo done on discharge. And if you can remember the previous echo, you could see that over the course of roughly 4 weeks, his cardiac functions almost came back to normal.
Right. So again, a few words about the prognosis, general theory. So how much of them survive the episode? You can appreciate that about 3 to 7% they die out of the complications within the hospital. These deaths are due to respiratory failure, ultimately leading to weaning failure, a lot of complications within the ICU, and the autonomic complications, both of which our patient had. Up to 20% are still significantly disabled at 6 months, and about 15 still have significant functional disability at 1 year, but we can just observe them further with good rehabilitation programs, involve the patient in good rehabilitation programs. Most of them have residual complaints because of the persistent axonal loss following the demyelination, and recurrence. There is a recurrence rate of about 5 to 7. So that was our patient. These were our references, and if you have any queries with regard to our battle in the ICU, you can just ask us if you have any comments or questions.
Thank you very much for that interesting patient presentation, Lilanti and Kunita. Yes, any queries? I think I see this type of patients, Itragama rehabilitation after prolonged illness and Guillain-Barré is a problem. They don't have recover. Who had this type of long battles, then again end up with another about 3-4 months with us before they can really get into their functional state. But some do fail after prolonged ICU care. I think the critical Guillain-Barré ongoing plus the critical illness, neuropathy and myopathy may be a cause that we get this severe form. So it's a long battle for them even after coming out of the ICU. Any other questions? Okay, in absence of any further questions, I would like to thank Dr. Lilanti and Kunita for that wonderful presentation and all our presenters today and those who are present here today. And our sponsors for today's meeting is Sidus from Hemas Pharmaceuticals. I'm very thankful for them for their continuous support for the specialty updates. And we have 2 certificates of appreciation. Dilshan, would you like to join here? We'll see you in next month with another specialty update. Thank you.